Morning to one and all present today. Welcome to the third and final episode of the Nephrology webinar series, hosted by the Euroimmune Academy. Today's topic is entitled Detection of PLA2R and Other Antigens in Renal Biopsies as a Cause of Primary Membranous Nephropathy. Following today's talk, we will have a questions and answers session with our presenter. If you do have any questions, please type them in the chat box on your screen and we will relay it to the speaker. Any unanswered questions will be addressed via email. Without further ado, it is my pleasure to introduce you to our speaker. Mr. Bernard Collins is the Technical Director of Research and Development, Immunopathology Unit at Massachusetts General Hospital, as well as an Associate in Pathology at Harvard Medical School. To, to date, he has co-authored more than 100 publications on the importance of immunofluorescence in the diagnosis in renal biopsies and renal disease. In conjunction with his colleagues, he has developed several diagnostic assays for the diagnoses of renal disease, including the first to report that C4D is a marker for antibody-mediated rejection in allograft kidney and cardiac biopsies, specific assays for ANCA detection, and a Western blot assay for the detection of anti-alpha 3 chain of type 4 collagen in patients with Goodpasture syndrome and anti-glomerular basement membrane disease. Mr. Collins, along with his colleagues, developed a Western blot assay for the detection of anti-PLA2R antibodies in serum, and then worked with Euroimmune so that Massachusetts General Hospital was the first lab in the US to offer their FDA-approved assay for the detection of anti-PLA2R antibodies in patients with membranous nephropathy. Welcome, Mr. Collins. I will pass it over to you to begin your presentation.
Thank you. A warm welcome to each of you, wherever you may be in the world today. I would like to speak to you, as you've heard, about the detection of PLA2R and other antigens in renal biopsies as a cause of primary membranous nephropathy. My disclosures, I have none at the present time. And a brief outline of what we're going to discuss today is the discovery of the membranous antigens, the PLA2R serology assays and THSD7A assays that we have experience with at Mass General Hospital in Boston. And we'll discuss our three-step amplified technique by immunofluorescence in frozen tissue for the detection of PLA2R and other antigens in membranous. We'll also talk about the diagnostic value of the PLA2R assays. And we have an unknown case that we recently had as a renal biopsy at Mass General Hospital. And we're going to walk through how we determine what the antigen was in this case for membranous. And we'll allude to some of the future developments of diagnostic techniques for membranous and some of the caveats that are associated with the techniques. The number of antigens that have been defined as causing primary membranous has really increased dramatically in the last couple of years. And this is due to these two techniques, basically. One being the reactivity of serum with the membranous glomerular deposits, and then doing Western blot or immunoblot, and cutting the blot out and doing mass spec on the protein band. And the membranous antigens that have been identified by using this technique have been PLA2R and THSD7A, HTRA1. The other technique that has been largely used by Sanjeev Sethi and others at Mayo is using laser-captured membranous glomeruli in renal biopsies, and then doing mass spec on those that isolate to determine the antigen, identify the antigen. And by identifying the antigen, then you're able to use a reference antibody to stain the putative antigen in the membranous deposits. And then you can also look at the colocalization of the putative antigen and IgG and the deposits by IF. You can also elute antibody from the kidney tissue and antibody transfer into experimental animals to recreate membranous. The antigens associated with membranous that have been defined using mass spec and laser capture microdissection are SEMA4 and 3b, Nell-1, NCAM1, protocoherin 7, exostosin 1, 2, and TGF-BR3. One of the things I would point out in SLE that exostosin is not the antigen. And so there is a search for what is the significance of finding exostosin in SLE patients. The first antigen was described by Larry Beck and Lawrence Beck and colleagues in 2009 and was reported in the New England Journal of Medicine. It was the M-type phospholipase A2 receptor. And this was groundbreaking results. It really changed the diagnosis of membranous, which, as you know, is one of the most common causes of nephrotic syndrome in adults. The second antigen was also reported about 5 years later by Larry and David Salant and Nicolas Thomas, and was also published in the New England Journal of Medicine. And the second antigen found was thrombospondin type 1 domain containing 7A. And this was incredible because it changed the way that we look at the treatment and the diagnosis in membranous, idiopathic membranous glomerulonephritis. By estimates, this is the approximate prevalence in adults. About 75% of patients that have membranous have the PLA2R antigen. And then there is approximately 3% that have THSD7A, another 3% for SEMA4 and 3b, and then 2% for Nell-1, 2% for NCAM1, and 2% for protocoherin. However, that still leaves 13% of unknown antigens. So the search is on for these other antigens. So it's exciting. Membranous nephropathy has suddenly been moved to the forefront, and it's very exciting to think about and entertain what it will account for these other 13% of membranous. I should add that this excludes SLE. It doesn't include allografts, and it doesn't include the proteins that are trapped in the deposits without detectable autoantibody, i.e. exostosin, for example. The other tool that is available for the identification of two of the autoantibodies in membranous is to use serological techniques. And soon after the report of Larry Beck and colleagues, we set out to come up with an assay that would allow us to detect in the serum of patients with PLA2R membranous an antibody to the phospholipase A2 receptor. And we developed a Western blot assay. And you see here, there is a band of recognition in lane 1 and lane 3. Lane 2 is completely negative. Lane 1 and 3 are the same patient. Lane 3, the patient serum is diluted 1 to 20, and in lane 1, it's diluted 1 to 100. There is a molecular weight rainbow standard here for determining the molecular weight antigen. As you see, the antigen identified is 185 kilodalton protein, which is the molecular weight of PLA2R. So we performed this assay up to 2014 when Eurommune's assay was available. And then we thought it prudent to evaluate and validate the sensitivity of the Euroimmune assay against our Western blot. And as you know, the assay from Euroimmune consists of indirect immunofluorescence and an ELISA, and we compared the results of these two assays to our Western blot results. The IF is performed in the Euroimmune assay is performed on biochips. It has tissue culture cells, HEC293, that have been transvected with a recombinant construct of PLA2R and a negative control construct. And the ELISA uses a purified human recombinant PLA2R receptor from transvected HEC293 cells as the antigen substrate. And these two images give you, this is a positive serum for PLA2R. And as you see, these are the tissue culture cells that has the construct of PLA2R in them. And you have very distinct staining. When it's tested on the control construct, the positive serum for PLA2R is totally negative. The other part of the assay is the ELISA, which uses a positive serum with dilutions that creates a standard curve and then allows you to calculate the concentration or the units for the unknown serum that you're testing for. Our results of that validation study showed very good sensitivity and specificity for the positive cases that we had determined by Western blot, and we also ran some negative cases. And it showed no reactivity with the control groups. The control group, one control group being other patients with immune complex disease, not membranous, and just other normal controls and other patient diagnosis. And so we concluded that the detection of anti-PLA2R using ELISA and indirect immunofluorescence provides a sensitive and a specific tool for the diagnosis of primary membranous, PLA2R membranous, I should say, when compared to Western blot. The additional advantage of the ELISA is quantitation, which is a potential use for marker of treatment response. And we'll talk more about that in the course of the presentation. The PLA2R assay by Euroimmune, as you know, is a FDA-approved test. And it consists, as I've mentioned, of the indirect immunofluorescence, which is either reported as positive or negative, and the ELISA. And the reference ranges for the ELISA is less than 14 relative units per ml is negative. Borderline is greater than 14 and less than 20 relative units per ml. And positive is greater than 20. So since the inception of the assay at our institution, which you heard we were the first to offer it in the United States, we have analyzed approximately 8,000 cases using this assay. And we have determined 344 positive PLA2R cases. Well, you might ask me, that seems to be a lower percentage than what is thought to be related to PLA2R membranous. Well, the reason being is that a lot of these sera are sent in to us as reference testing. And they're usually, the test is used as a screening test because often the patient may just have proteinuria and not membranous. And as you know, there are other renal diseases that cause proteinuria. So that explains the lower incidence of what we've found for positivity in these patients. The other advantage of following the titer of these patients for PLA2R antibody levels is the fact is you can monitor the disease, and also it is allowed the development of different treatment protocols and clinical trials for immunosuppressing the level of antibody in the circulation and its effect on the course of the disease. And this is a study that we published. It was Reza Zanozzi was the author in this case. We published this recently in 2021. And it treated patients, membranous patients, with a combination of Rituxan and low-dose cyclophosphamide and prednisone. It was a a case series with an extended follow-up, and the results showed that all patients with primary membranous treated with a combination therapy achieved partial remission, and most achieved a durable, complete remission with an acceptable safety profile. Others have also reported the prognostic value and treatment value for following the titer of these autoantibodies in membranous. This was a single center study, longitudinally followed for 14 years in Europe, and it showed the prognostic value of PLA2R autoimmunity detected by measurement of anti-PLA2R antibodies combined with the detection of PLA2R antigen in the deposits. Their conclusions were that assessment of anti-PLA2R antibody is essential for patient management, which we've already mentioned, and the combination of PLA2R antibody titering and the detection of PLA2R in the immune deposits in renal biopsy increases the diagnostic sensitivity. And PLA2R antibody titer is a biomarker of disease. This was published by Pierre Ronco in Europe. The Kidney Disease Improving Global Outcome Guide for 2021 for the management of glomerular disease recommends that no renal biopsy for the diagnosis of membranous in patients with a positive PLA2R result and preserved renal function, and no other comorbidities, which is an interesting, interesting recommendation. One of the things I would like to point out is that in patients that are seronegative for anti-PLA2R, you still can have PLA2R glomerular immune deposits. And we published this in, at the ASN in 2012, showing that in seronegative patients, you certainly can have PLA2R. This is a patient that was negative for PLA2R by testing. But as you can see, we stain for the PLA2R antigen here, and you see very distinct granular staining for the antigen, and the major IgG subclass is IgG4, and when it is merged, you have yellow, thus showing that the PLA2R is in the deposits. This has also been confirmed. The second autoantibody that we look for in membranous is the anti-THSD7A antibody, and that is done simply by indirect fluorescence. It's an indirect fluorescence biochip mosaic technology. The reference range is either positive or negative. Positive is greater than a 1 to 10 dilution of the patient's serum. Any patient that is found to be positive at greater than 1 to 10, we do titering on. And since we started doing the assay in 2018, we have analyzed more than 4,000 cases, and 5 of those cases have been positive for THSD7A. There again, that's a low number. It's the percentage, as you know, as you recall, is 3% as a cause for primary membranous, but this number is much lower, and that's because this test is used for screening patients with proteinuria, for example. So we pursued in the last few months working on trying to identify some of the new antigens in membranous in tissue. And we used renal biopsy frozen material, and our preference is to use immunofluorescence on frozen tissue. And we also use colocalization of the antigen with the IgG subclass in the deposits. What has allowed us to do that is a very powerful technique that we developed, and it is a 3-step amplified technique for immunofluorescence that allows us to stain. It's the avidin biotin system, It allows us to stain for the antigen. We also stain for the colocalization for IgG4 at the same time. The second layer of antibody is using a rabbit anti-PLA2R polyclonal antibody. And the bridging antibody is a biotilated goat anti-rabbit, and it is detected, the signal is detected by using Cy3 stratavenate. This is a very specific assay and very sensitive. And we have used that for our attempt to identify these new antigens in membranous. And just revisiting our pie map, just the percentages, there is a dilemma. The question is, if you have a patient that has histological findings that is suggestive of membranous, your question is, which direction do I go in order to try to uncover what the antigen is in this case of membranous that is not PLA2R or not THSD7A positive? So that was our dilemma. We have a number of patients that have membranous that are negative for PLA2R and they're negative for THSD7A. And so the question is, in what direction do we go? Well, one of the things I came up with is I thought perhaps that I could try to call colleagues and ask them if they have any positive cases for the new antigens of membranous that we could try to use as a positive control with our three-step amplified technique, immunofluorescence technique. And this is our PLA2R. I should point out that that was the first antigen that we detected in membranous. When we stain it directly, we use a green label. But when we do the co-localization with the IgG subclass, we switch to red because our IgG subclasses are FITC directly conjugated. So that's why there's a difference in the color of the antigen. So as I said, I contacted colleagues, and this was the first case. This is a case from Beth Israel Hospital in Boston, Dr. Isaac Stuhlman, who is a friend and colleague. We had tested this patient because, as I mentioned earlier, we do reference testing for other hospitals in the Boston area and outside of Massachusetts. And so we had tested this patient for THSD7A. It had a very high titer. I called Isaac and I asked, is there any possibility that you might have frozen tissue in this case? And he said, I will check. And lo and behold, he had some, and which was really great news. So he sent it over to us, and we stained for THSD7A using our three-step amplified immunofluorescence technique in frozen tissue. And we also did the subclasses in this case and determined, as is the case with PLA2R, the predominant IgG subclass is IgG4. So as I had mentioned, we switched to the red color for the colocalization, which you see the staining for the antigen here, and then we merge, and you see that there's yellow. So denoting that the IgG4 and the THS7A antigen are in the same location in the immune deposits. This is a second case that was provided to me by a colleague from Columbia, Dr. Ibrahim Batel. This is part of some of the patients, a series that they had published from Columbia. So he sent me a positive Nell-1 case. We stained it with our antibody. And what do you recognize that's a little unusual about this staining for the antigen? It's somewhat segmental, and it's called the segmental membranous, which is really interesting. You can see there are negative loops of the GBM, and they're very discrete positive granular staining in other GBMs. In contrast to the PLA2R and the THSD7A, the predominant subclass in Nell-1 membranous nephritis is IgG1. And so we did stain it for subclasses, and that's what we detected, IgG1. We switched to the red color for the antigen, and we did co-localization. And as you see, the co-localization is segmental, as is the distribution of the IgG in the GBM. We did not have any luck. I contacted Sanjeev Sethi at the Mayo, and he wasn't able to give me any frozen tissue that we could use for exostosin. But we looked at our database of negative cases of PLA2R that had SLE, and the first case we stained was positive. And you can see the staining for the antigen here. And the interesting thing about exostosin positive lupus cases is that membranous lupus cases, is the fact that it has all 4 subclasses, as you can see here, IgG 1, 2, 3, and 4. So we had a tall order to do. We needed to do co-localization with all 4 of the subclasses, and that's what we did. Very prominent IgG1, the antigen, and then co-localized, as you can see, IgG2, exostosin 1, 2, and the co-localization, and 3, IgG3, exostosin, the merged image, and IgG4, exostosin, and the merged image. Another thing to keep in mind is, is membranous after kidney transplant. You can have recurrent membranous, or you can have de novo membranous. And this brings up a couple of interesting points. In contrast, the top 3 images represent a PLA2R positive membranous case. And as you've seen in multiple images that I've showed, there's very prominent IgG4, prominent PLA2R in a granular location in the GBM, and when it's merged, there's yellow. In contrast with that is a post-transplant de novo membranous case. And what do you see? You see very bright granular staining in the GBM, but the staining for PLA2R is not in the GBM. It's more on the podocyte, as you can see here. And when you co-localize, you have Christmas colors here, green in the GBM and red on the podocyte, showing that there's no co-localization in patients, in this patient with de novo membranous post-transplant. In contrast, recurrent membranous, bright granular staining in the GBM, prominent staining in the GBM for the PLA2R antigen, and when you merge, you have a mixture. There's yellow and there's green. And that's probably related to the time course of which this biopsy was performed. I would predict that if you biopsy this patient later, you might see more co-localization, but that's something to keep in mind. One of the things we have reported back in 2010 is that de novo membranous is a form of chronic humoral rejection, and it correlates with C4d deposition and donor-specific antibodies. This is a patient with de novo membranous, and as you can see, there's very bright granular staining in the GBM. But in addition to that, there's diffuse staining of the peritubular capillaries. These capillaries are dilated, denoting humoral rejection. This is a tubule here, which is the larger structure. This is pathognomonic diagnostic for antibody-mediated rejection. This is an assay we developed a number of years ago and has now become a standard of care for transplant patients across the world. This is the PAS, which shows thickened GBM, characteristic of membranous nephritis. And when you look in the electron micrograph, you can see the membranous deposits in the glomerular basement membrane here. This was also reported a year later by a study out of Japan, de novo membranous nephropathy and antibody-mediated rejection in transplanted kidney. There is DSA and AMR might play some roles for the pathogenesis in some patients with de novo membranous after kidney transplantation. This is not all patients, but it's a subset of patients that develop de novo membranous post-transplant. The other interesting finding that has been reported in the literature was from France and Germany, and it shows recurrent membranous in an allograft caused by IgG3 kappa restricted antibody that targets the PLA2R receptor. The patient had recurrence 13 days post-transplant. The indication for the biopsy was delayed graft function and proteinuria, and the biopsy showed granular C3, and what's interesting is it had very striking C5b9 and C1q. Well, what is unusual about that? In idiopathic membranous, you do not usually see the terminal components of the complement activation cascade. This is very unusual. C1q and C5b9 is usually negative. It was the IgG3 kappa restricted antibody in the immune deposits, and it was positive for PLA2R. We have also we have preliminary results showing that a few cases of positive PLA2R cases that have very high titer, greater than 1,500 RU per ml. Remember I said the positive level was greater than 20. This is extremely high. And we found that there is light chain restriction in a small number of those patients. We are continuing to try to determine what the incidence of this is in patients with high levels of PLA2R. As I mentioned earlier, a lot of our specimens are reference specimens, and so we don't get clinical histories at all on those patients, and it requires lots of phone calls and trying to find out, one, if there's ever been a biopsy, and also the course of the disease, which is of interest. This you see are the transvected cells that have the control construct of that have the PLA2R construct in them. And this is detected with a specific antibody to kappa after the incubation with the patient's serum. And you can see it, the patient's serum reacts and is detected using the kappa probe, but there is no detection using the lambda probe. More to come on that aspect. So one of the things that you can use is this suggested algorithm for trying to help you decide in which direction you're going to use to try to identify what the antigen is. And one of the most important things is, one of the most important things to do is to think about, is there an autoimmune history in addition to membranous? The IgG pattern of staining, whether it's global or segmental, and we're going to have a little exercise we're going to use this algorithm to help us, to walk us through in what direction we're going to use to try to determine an unknown antigen in membranous. Whether it's an adult or whether the patient is a child, whether it's monotypic. As you know, monoclonal immunoglobulin deposition disease is an important thing to take into consideration when you see light chain restriction, for example. And also, is it in the transplant setting? The other thing is helpful are the characteristics of the antigen. One is obviously the molecular weight. Also, whether in what compartment whether it's transmembrane or secreted, and whether it's on the podocyte or not. And one of the things you see here is that Nell-1 is not on the podocyte, and protocadherin 7 is not on the podocyte, and whether there are circulating antibodies to it, whether the age of the patient and sex, and whether there are other distinctive associations. And we're going to talk more about a distinctive association in our unknown patient that we're going to work through. And also just keep in mind that the exostosin 1, 2, there's a question about what the significance of that is in the immune deposits with patients in SLE. one of the most important things to take into consideration is the predominant subclass. And this chart gives you a very nice breakdown of the subclasses. As you've seen already, the predominant IgG subclass for PLA2R and THSD7A is IgG4, and Nell-1, the case that I showed you, is IgG1. Our case of exostosin was all 4 subclasses. So there are a few caveats associated with the detection of these antigens. So far, there are few case reports for these new antigens, so there's limited knowledge. The other thing that is that's on the landscape is the recommendation of the KDIGO that biopsy frequency may be changing because clinicians may be less inclined to biopsy the patient. But as I pointed out, a negative serology but for PLA2R does not exclude PLA2R membranous, and the only way to determine that is a renal biopsy. So those factors have to be taken into consideration to guide the clinician of whether they make the decision to biopsy the patient or not. And as I've said, occasionally you have these negative patients that are positive. And the distinctive proteins in the deposits may not be the antigen. And an example of that, if you've heard a couple of times that I've mentioned, is the exostosin 1,2. And the diagnostic technique for determining these new antigens, it may evolve with more time. This is an old study that we published back in 1974, and it shows that proteins are not antigens that can accumulate in the membranous deposits. This shows ferritin that localized in the deposits of heminephritis. And as you know, heminephritis was thought to be a model for membranous, but it turns out the antigen in heminephritis is megalin. It's been associated with anti-TBM disease now in humans, which we reported on several cases. But horseradish peroxidase accumulated non-specifically in these immune deposits. So that's something to keep in mind. Because the antigen, because there is a protein there, it may not be the antigen. So that's something to keep in mind. Now, this case presented just recently after we had worked up these positive cases for the antigen. And this was a 34-year-old man. He presents with incomplete tetraplegia and has multiple complications, recurrent urinary tract infection, and he presents for the evaluation of proteinuria. A few lab results show that his creatinine was 0.6. He was anti-PLA2R, SPAP, and free light chains were all normal. And by ultrasound, he had normal-sized kidneys. And so a renal biopsy was performed. And the renal biopsy showed a very extensive infiltrate, as you can see here, probably indicative of the multiple infections he has and probably represents chronic pyelonephritis. The tubules were preserved, as you can see here. And by H&E, you can see that there's maybe focal hypercellularity, but as a whole, no. There's this sort of thickened GBM that you see in the image. And by PAS, you see thickened GBM also, and nephrosclerosis and arteriosis. And when we stain the biopsy for our immunofluorescence panel, it's a little hard to interpret this image. And why? Well, because a lot of this staining is linear. And I think on first glance, when we looked at this case, we were somewhat put to decide whether there was any granular staining in it at all. And I'm harboring on that because we're going to find out as the plot thickens why I am concerned about this. I mean, I think you might be convinced that segmentally here, there are a few granules, but it's very hard to interpret, perhaps here, but it's very hard to interpret because of the linear staining. As you know, the GBM has a propensity to have a linear staining, and that's why albumin is important in evaluating whether you think that the linear staining of the IgG is significant or not, i.e. anti-GBM disease or Goodpasture syndrome. In comparison to that is the albumin stain, and as you see, it's very linear. So that was the dilemma we had. So we saw linear staining basically through IgG and maybe a few granules, but didn't make much of it. And the IgA was negative, the IgM was negative, and by C3 you see that there is some of these granules here are epithelial reabsorption droplets, which just denotes proteinuria. But there's a line here of granules, and there may be some granules here, and then there was a scarring pattern for C3. The C1q was negative, and both light chains had a little segmental granular staining, as you can see, but very limited. But our eyes were amazed when we saw the electron micrograph. What do we see? We see immune deposits in the GBM, very characteristic of membranous. I hope everyone can appreciate that. And so this was a dilemma. And we said, well, we went back and looked at the fluorescence again, and we said, perhaps there is some linear staining there. We looked in the mesangium. There were no mesangial deposits. But as you can see, another power of the electron micrograph, you can see segments that have no staining, which corresponds to possibly a little bit of segmental staining that we saw in the IgG, but we had difficulty really determining that. So we reviewed our chart again, and we said, in which direction do we start? Well, I think that one of the things I concentrated on, and I will use the algorithm to reinforce that, is the fact that we wanted to concentrate on the staining. So we wanted to use our three-step amplified technique. We don't have in our lab setup the ability to do these other tests. I mean, we certainly can do Western blot, but prefer not to. And we don't have mass spec, and we don't have laser capture microdissection apparatus. So we used our three-step staining technique, and we also consulted the algorithm. Now, the patient really doesn't have any history that we know of autoimmune disease, but one of the things we do have is we have possibly a segmental pattern as opposed to a global pattern. So this led me down the path of the first antigen, new antigen for membranous to exclude would be Nell-1. It's not a child, it's not monotypic, and it's not the transplant setting. So we repeated the IgG in order to do co-localization with PLA2R. We knew that the PLA2R serologically was negative, but as I've reported in earlier studies, we showed that you can have a negative PLA2R and still have PLA2R in the immune deposits. So we stained for IgG, and then we stained for IgG4. And we did co-localization. Now, what do you see here? There is no IgG4, and there is no PLA2R. So this confirms the serological results. And when we did the co-localization, we had to do it with IgG. So the IgG and PLA2R have there's no co-localization. You see some of the PLA2R, which is on the podocyte, the normal distribution that you see here. This is what the normal PLA2R positive case looks like, as you've seen in multiple times in this presentation. And so we honed in. One, we have the segmental staining, possibly by IgG. We don't have any IgG4, So the question was, what is the IgG subclass? So that's just a reminder that the importance of the IgG subclass. So we stained for IgG 1 and 2, and you can see that it is IgG 1, no IgG 2, no IgG 3, and no IgG 4. So we have a segmental membranous pattern with a primary IgG subclass of IgG 1. So we got our antibody out to Nell-1 and we stained it, and these are the results. We had distinct segmental granular staining for the PLA for the Nell-1 antigen. Very discrete granular staining. I think that one of the things that the learning point here is that we would have been we did the colocalization of the IgG1 in PLA2R, I mean in Nell-1, and it colocalizes. I think that had we stopped, or had we not had the EM, we probably wouldn't have proceeded, and we would have said that the staining by IgG was probably insignificant. And I just want to stress the important fact is that you really have to take into consideration the three parts of the workup, the diagnostic workup for a renal biopsy, and take into account the results of those, because they each can be very helpful and in guiding you in the right direction for making a diagnosis. So the diagnosis here: membranous glomerulonephritis, Nell-1 associated. There was arteriosclerosis and arteriohyalinosis that I showed you, and there was chronic inflammation, which probably favors chronic pyelonephritis, and there were chronic parenchymal changes in this patient. There was about 50% global glomerulosclerosis, and we saw that in the C3. There was a segmental scarring pattern for staining in the C3, and there was about 15 to 20% interstitial fibrosis and tubular atrophy. We ran in conjunction with the case, we ran our positive control that we had gotten from Columbia, which shows clearly the segmental granular pattern, unlike our case, which was really difficult to interpret, and with the principal IgG subclass being IgG1 and segmental Nell-1, and then the merge with a segmental pattern. The Nell-1 was described in 2020 by Sanjeev Sethi and Pierre Ranco and colleagues from the Mayo and other and Paris, I should say. It's really interesting that this case turned out to be Nell-1. The other thing to keep in mind is the association. This patient was male, and it tends to be in older patients. And there is a malignancy preponderance in about 33% of the cases, which at the present time, it's not known that the patient has a malignancy, but they're actually excluding that now. And future diagnostic techniques for membranous. Euroimmune has said that they have signed a license agreement for the development of an assay for the detection of Nell-1 antibodies. There's a need, of course, for exostosin 1, 2, and semaphorin 3B assays for detection. And also, hopefully there might be a possibility of a development of a microarray or similar technology for the identification of the membranous antigen, which would be very useful, which you could simply screen for a number of antigens using the microarray technology. I would like to thank my collaborators and the renal and EM labs here at Mass General, and my colleagues here at Mass General. And I thank you for your attention, and I'm open for questions at this time.
Thank you so much, Mr. Collins, for a terrific presentation. So we've received quite a few questions in the chat during your talk, so we'll now move on to the question and answer session.
Okay.
Yep, so the first question is regarding serological testing. It was asked, in what cases would you use both ELISA and IFA or would you typically just use one technique over another?
We actually, well, for using the serology testing or the tissue testing. Sorry, I'm sorry.
This would be for serology, I would think. Do
Well,
you know? Mhm.
we routinely perform both the assays. I mean, both assays are
Okay.
performed.
Yeah. Okay.
We do the indirect fluorescence, and
Mm-hmm.
we also do the ELISA. We
Would you?
perform
Mm-hmm.
we perform both assays. Both your
Okay.
Right, both Euroimmune assays. And what we do is, for patients that are negative for PLA2R,
Mm-hmm.
we offer the possibility that the clinician can request that we do a reflex test. So if it's negative for PLA2R, we will reflex and do THSD7A. And that's actually how we found the patient from Beth Israel Hospital that was positive for THSD7A. They were negative for PLA2R, but they had a very high titer for the THSD7A. Right.
Yeah, great. Thank you. That answers the question,
Oh,
definitely.
good. Good.
And another question about, I guess, serological testing would be, what would be a possible advantage? Is there an advantage of using Western blot versus ELISA for the detection of anti-PLA2R antibodies, or is ELISA just more advantageous, would you say?
I think the advantage, as I mentioned, I think the advantage of the ELISA is the fact that you get a number, you get a quantitation, as
Hmm,
opposed to the Western
right.
blot. The Western blot is, I mean, you can certainly say, oh, the band is very prominent or the band is dim. There is a little correlation to that, but also just keep in mind some patients that have very high level of antibody can have a negative Western blot, and this is caused by the prozone effect. And so that's something to keep in mind.
Hmm,
Um, I what I can say is that after we did our little mini validation of Western blot against the serological tests that are available from Euroimmune, we stopped doing the Western blot.
hmm,
It's labor intensive to maintain the antigen.
mhm.
You have to do the isolation, and it's multi-step, and you have to do the transfer, obviously, and you have to do so it's a more, and the fact that the Euroimmune assay is FDA approved. I mean, our
Right.
Western blot wasn't,
Yeah.
so that's one of the real advantages of it. And
Great.
also it means
Mhm.
that, you can compare, between different centers. You can compare your results to those because you're using the same assay.
Of course.
And I think that we were one of the few, I don't know anybody else that was doing, for
Mhm.
research purposes. I know that Larry Beck, a colleague, as you know, who has been a mover and shaker in defining the antigens in membranous, he
Mhm.
uses the Western blot, but it's for research. It's for research purposes.
Mhm. Right. Yep. Thank you so much.
Sure.
Um, so the next question is regarding prevalence of the different types of antibodies in membranous. So does the prevalence of these antibodies, for example, Nell-1, PLA2R, I think you touched on this, vary by age or demographic?
Um, I'm sorry, I don't do. Oh, whether the antibodies themselves?
Right. Yeah. So are certain sort of antibodies Nell-1 found in, or more selectively in certain populations over
Oh,
other
yes,
populations?
yes, and I showed, as I showed, depending on the age, the algorithm
Age.
that I presented, it gives you, the breakdown.
Mm-hmm.
Sema4 and 3B, for example, is in children.
Right.
Yeah, and the others are, and there's also a sex difference too. There's a preponderance sometime of male versus female in these,
Mm-hmm.
and also the age can vary. Um, uh, uh, can vary. For example, the Nell-1, the patients are mainly male and they're older. Yeah,
Mm-hmm.
mhm.
Yep.
And also the association with malignancies too.
Mm-hmm. Yeah. Thank you.
Sure.
So the next question asks if you've ever had any experience with chemiluminescence immunoassays, possibly for antibody detection.
We have historically, but we don't use them, but we
Okay.
have. Uh-huh.
And yeah, they ask what would possibly be an advantage of, a CLIA assay. Is it more sensitive, for example, over ELISA? Do you know?
I think that you would have to evaluate the sensitivity against the assay and the ELISA.
Hmm.
I think it would require validation.
Hmm.
Mhm.
Okay. So the next question we can move on to asks, what's the prevalence of a negative ELISA or IFA result of anti-PLA2R with a positive PLA2R detection renal biopsy? So how often, I guess, would you not be able to detect with ELISA or IFA, but see that PLA2R is
Plus,
present in biopsy?
and the biopsy. This is all anecdotal. We don't have good numbers for that correlation. I think that one of the things to keep in mind with membranous, as you know, the disease can certainly have spontaneous remission for no reason.
Hmm.
Um, and I think that that might be one of the reasons that you might have a negative serological result, and yet still have PLA2R, for example, in the immune deposits. But we don't have good numbers on that that correlation.
Hmm.
I think that one of the things I brought up is a lot of the sera that we test are from the outside, and we have no clinical history on those patients. So the correlation of biopsies,
Hmm.
whether a biopsy was done and did it show membranous,
Right.
so I think that that's the difficult thing.
Mm-hmm.
That would be a difficult thing to determine. I think it would require a lot of research between the institutions that have sent us specimens.
Mm, I got it. Okay. Thank you. We'll move on to the next question, which just came in, I believe. May we measure? Yeah. So is sort of the algorithm to measure IgG subclasses if PLA2R is positive? Is what was asked.
Well, what we do, we always, even if we have a case of membranous and say we have a positive serological test, we always do colocalization for PLA2R. I mean, it's just part of our protocol for working up the
Hmm.
renal biopsy.
Hmm.
Any membranous case we as in addition to the routine immunofluorescence panel, we do colocalization on for PLA2R.
Hmm.
And obviously, a real red flag would be when you do when you do IgG and you do IgG4 and you do the colocalization with those two with the PLA2R antigen. And so if you have a negative IgG4, that raises a question. And as you saw in our unknown case that we worked
Hmm.
through, the IgG4 was negative. So that triggered to say we need to do the IgG subclasses. And I
Right.
think that's often the case is that we'll do the colocalization and perhaps we find that there's no IgG4. So then we reflex and do the IgG subclasses.
Yeah. Gotcha. Thank you.
You're welcome.
I'll move on to the next question. It's sort of about dual positivity. Do you ever see anti-THSC7 antibodies found along with PLA2R antibodies in any case?
You know, our experience so far since we've just started developing the detection of these antigens, we've not had a case so far. I mean, our case that I presented that was THSD7A positive that was given to us by Dr. Stillman from Beth Israel was negative for PLA2R. But as you know, it's been reported in the literature. Chris Larson, for example, with Larry, have reported double positive patients, PLA2R and THSD7A. But I think our knowledge right now at MGH is somewhat limited. I mean, we're going to explore that possibility. And I think that one of the things that we're going to do
Hmm.
uh, in the fact now that we have developed the ability to stain for these new antigens is that we're going to look at some of our unknown cases and consult, clinical histories and try to determine if we have any double positive cases. But
Okay.
right now, we have not seen double positive cases.
Hmm. Okay, great. I'll follow up with another question. So are there examples of other MN, membranous associated antigens that are not found on the podocyte aside from Nell-1 and protocadherin 7?
That's so far. I mean, I think that's in the
Okay.
literature. So that's what's in the literature now. But I think the point is that with these very um, very these new techniques, that might change. And that was one of the things and the caveats that I talked about, is that this is evolving, and I think it will evolve, and I think that more is to come based on these very valuable techniques for defining membranous
Mm-hmm.
antigens. Yes.
Yeah, thank you. We
Sure.
just had another question come in. In an ELISA or a cell-based assay, would an Ig subclass conjugate be useful?
It could be. Sure. Yeah. Yeah. I think so.
Okay. And another question we had was, what's the significance of segmental staining?
This is an interesting phenomena. The etiology, I mean, the development of the disease, it's unclear to us. I mean, it's something that we would like to explore, but what causes the immune deposits to be segmental? I don't think we have an answer right now, and I think it's going to require more investigation.
Yeah. Thank you. And so now we're getting to the end of the questions that we had sent into the chat. If there's any more questions, please type them now. In the meantime, Mr. Collins, if maybe you could just end with your thoughts on the future of, membranous testing, what's sort of needed. I know you did mention this a little bit, but if you could just speak to that, I think that'd be a great way to wrap
Sure.
up.
I think that it's an exciting time in the diagnosis of membranous.
Hmm.
It is incredible, and I think that there's only going to be more. There's only going to be more antigens that are identified, because you recall we still have 13%
Hmm.
that the antigens are unknown.
Hmm.
And I think with the newer techniques and this micro laser capture dissection and mass spec, we're going to identify some of the other antigens that are in there. I think that one of the things that would be most helpful for the future is, I think it's probably one of the last things that I mentioned in what's coming in the pike, was the fact is, could there be antigens that are on a microarray so that you could test for a number of antigens, which I think is really would be very helpful and would save a lot of time, actually, and be very diagnostic, and the patient would benefit in making that decision, or making that discovery in a quicker time frame. And I think that one of the things that you hopefully understood is, in our case, our unknown case, that required several tests until we unraveled what the antigen was. I mean, I think the algorithm is very helpful in that respect, but it requires personnel in the lab that you can train in order to do the additional testing, because it's not the ordinary testing. And so I think that that's also something to keep in mind, is that depending on what your staff is in your pathology lab, you may be limited about how much you can do. And so I think the microarray technology could be very helpful in streamlining and getting more information in a much shorter time period. Because for this case, for example, it took us the better part of a week to work through this. So with newer techniques, you might be able to check in a day or so and determine if you have one of the other antigens. Yes.
Yeah, of course. Thank you so much. And we actually did have another question come in, so we can
Okay.
move on to that one. And it was asked, is it true that the correlation of non-PLA2R autoantibodies with disease severity is less established?
I think there's not a lot of data on that yet. I think that it's evolving. Yes, I think the concentration has been on the patients that are positive, because you can measure something. In negative patients, what do you measure that is indicative of improvement or exacerbation of the disease? And that's going back to what we said earlier, is that's the real value of doing the ELISA, is you get a number and you can follow that number. And the clinician can interpret that. If I have a patient that has a very high level of anti-PLA2R, then I need to do something to reduce that level in order to help in the improvement of the renal function. And so then there are sequential samples that are sent in, and we follow those patients longitudinally. And those numbers are very helpful to the clinician to provide him some sort of information. Is my patient getting better, as measured by the level of antibody?
Thank you so much. And with that, we will wrap it up here. I want to thank again our speaker, Mr. Collins. I think, it was very insightful, and I think that all attendees will have agreed and, learned something today. And if you're interested in receiving PACE credits, please click the link that is in the chat right there. And that link would also be sent to you via email in a follow-up email. On June 15th, we have an autoimmune neurology summit. This is a one-day virtual event hosting 15 medical experts in the field of neuroimmunology. And so stay tuned for registration invites to your email. And we thank everyone again for coming, and I hope you have a great rest of the day.
And I would just like to add one thing. I would like to thank you for your invite. It's been an honor and a privilege to give this a webinar today. And it's exciting that people from all over have tuned in. It's very exciting, and I wish everyone, wherever you are in the world, a very pleasant continuation of your day. And I know that differs where we are. And I look forward to seeing you in the future somehow.
Thank you so much, and we were honored to have you. Thank you.
Thank you, Ilana.
All right. Goodbye.
Bye.